name is Sandro Galea. I serve as Dean of the WashU School of Public Health. Welcome to Public Health Ideas. These are conversations that aim to highlight work that advances the science of health. Today, I have the privilege of speaking with Professor Debra Haire-Joshu. Professor Haire-Joshu holds the Joyce and Chauncy Buchheit Professorship in Public Health at the School of Public Health. She also serves as Associate Dean of Faculty Affairs at the school and directs the Center for Obesity Prevention and Policy Research and the Washington University Center for Diabetes Translation Research. Today, we're going to be discussing her paper in Health Services Research, Advancing Healthcare Equity Through Dissemination and Implementation Science. Debra, welcome.
Thank you.
So let's start with the paper itself. Where did it come from? What were you trying to ask in this paper?
Okay, so the paper was actually the product of some work I had done with the Agency for Healthcare Research and Quality, AHRQ. A few years ago, AHRQ was very committed to doing equity work. They wanted to better build equity within their research moving forward, the portfolio. And so they developed a summit. They did a healthcare summit and invited around 50 community leaders, members to come in and talk about what was needed to address inequities in healthcare. From that summit, they came out with several areas of interest: access to care, issues around payment models, systems of care, and implementation science. That those were some of the themes and the discussions that came out of that two-day summit. And so at that point, they asked if I would lead a team and do a paper around implementation science and health equity, and use the information that we had to really inform their work moving forward, their whole framework, their whole ideas around how they wanted to do the portfolio over the next decade or so of what they were going to do. From that point, when I agreed to do it, I had to put together a team. Anna Bowman here at Washington University, implementation scientist, agreed to lead the paper. Rachel Shelton, who was out of Columbia University, done a lot around equity, also agreed. And then, of course, Shriki Kumanyika, who is just an amazing leader in this field, graciously agreed to come on. So the four of us were really commissioned to do this paper around health equity and implementation science.
Tell us a little bit about the summit. What were those conversations in the summit, and how did they eventually become the paper?
So from that summit, we did an outline on our paper, and we went to a two-day summit where we sat with community members, partners. We were divided up into small groups to get information, and they looked at our outline. They went through our outline line by line and talked about what they thought was there, talked about what they thought was missing, talked about where we thought we were duplicative of what was being done, and how we needed to push the envelope moving forward. And we had, it was 2 days. We got some really intense feedback, and it helped us to think through how we wanted to move forward with themes or with ideas for the paper, and how we wanted to approach the literature. We were going to do a narrative review and look at the papers that were already out there. A lot of the papers were written here at WashU, actually, so I was familiar with a lot of them. And we looked at those, and we also went to other disciplines to look and see how they talked about implementation, how they talked about what they thought was needed in their fields moving forward, to try to get a good sense of how we might approach this in healthcare.
Tell us a little bit, take a step back for a second.
Okay.
Dissemination and implementation science. Can you briefly describe the field?
Okay, so for dissemination science, what I really say about that is that in short, it's the spread of information to targeted groups. So when we have evidence that we've learned from science, we want to get that evidence out, let's say to policymakers, so that they can take that and use that to construct or implement their policies. Dissemination science is a way of targeting and making sure that information gets out effectively. Because you can have misinformation, you can have all kinds of things go awry. This is in part and parcel to what that is. Implementation science is really, we know what we do, it's not always clear how we do it. So it's to me, I think of it as, when we do drug trials, we have a pill, we kind of know what that pill is, antihypertensive. We give that pill and it fixes hypertension. What happens in between? We look and see at the mechanisms that what happens in between. In implementation science, you get key ingredients from evidence, you put them together in an intervention, and you look to understand what happens in between. And there are certain processes, steps, and methods you go through in doing that. And if you do it effectively, it's going to work most effectively with the population or the people or the community you're using it with.
Take us a little bit through the themes at the intersection of dissemination, implementation, science, and healthcare equity. So what emerged?
So we decided to call them principles because we felt like that was more in keeping with our approach and more in keeping with our narrative review. And the first one was that racism is inherent in inequities. That this was something that we needed to acknowledge, that we needed to approach, and that we needed to understand if we were going to talk about equitable impact, we needed to start with the idea that racism was inherent in our policies, our procedures, and that we at least had to acknowledge or look and see how that might have impacted that historically and currently. We also acknowledged that context was important. Every context is different. An evidence-based intervention that is developed at WashU with all the resources we have in a clinical setting is not going to work in the Boot Heel of Missouri if you don't understand contextually what is different. And so that was the other piece that we had. That we understood that equitable healthcare then meant that you had to have community engagement, that you co-design the intervention to fit within the context, and to understand the policies and procedures that are already in place, and that you need multi-sectoral partners. We cannot do one-to-one, doesn't work. You have to look at schools, you have to look at communities, you have to look at governments, and you have to understand the impact of the policies on the context and how those policies may have began or developed over time. So those were really the four principles around racism, around context, around partnership, and around multi-sectoral partners and community engagement.
So where does this go? What are directions for research and for work in this space?
We came out of this with a series of 8 recommendations, and we divided them up into 3 buckets. I love buckets, makes more sense to me. So we did it around approaches, and the approaches that we identified were that we needed first to expand the evidence base for evidence-based interventions in different populations, across different regions, that there needed to be more evidence around, other than the clinical trials that come out and say, let's go with this. We had to have more contextual kinds of things. That we had to foster adaptation. That any intervention that we have that is developed, the WashU intervention, a wonderful clinical intervention that we develop around diabetes prevention, we take that to the boot heel. We need to adapt that. We need to work with the community to adapt that carefully so that it works with that population, and we need to make sure we have methods and procedures to better do that, more effectively do that. We need to really work to de-implement what doesn't work. A lot of the communities that I've worked with, especially in healthcare settings, they may have a screening process which is really out of date. It's not up with the science. It's not appropriate in some fashion, but to them it's something that's better than nothing. And de-implementation implies sometimes jobs go away. So we say, oh, let's go in and de-implement and put in something different, and the community's like, whoa, wait a minute. There's other things attached to that. And misimplementation. How many times have we seen things that maybe get implemented incorrectly, but the community likes it, so they leave it there. So the idea being that we work with the community to address all of these things that are going on in the healthcare setting so that it works within their context, and to make it so that they're okay with how we do it, that we don't just drop in and helicopter in around that. And then finally, that we measure what we do. So a lot of times we don't pay attention to equity markers, or the appropriate equity markers, which sometimes are around race and ethnicity, are not included. And so that could be a challenge even today, how that is done. And then finally, we did recommendations around capacity building. Implementation science is really, we've got so much that we do in the academic setting. We don't do a whole lot around practitioners to make it work effectively in guiding practice in the real world. And so there has to be more around that. If we want people to do it, we have to help them to understand in a way it works.
My last question. What do you think is the most interesting and exciting area where the field is headed?
For the field moving forward?
Yeah.
I personally think adaptation, because I think we have so much science, Sandro, that sits There was so much science, and I always go back to the DPP because it was such an amazing trial, and we've got this tsunami of diabetes and pre-diabetes, that we could do so much to impact. We could do so much to impact with mothers and children. They get gestational diabetes and they're going to convert in 5 years. There's so much we could do with DPP. We know that it works. It hasn't adapted in a way that it works outside. It's adapted some, but it hasn't adapted near what it should to address that. We have great science, and we need to get that science out better. So,
Debra, thanks for the work you're doing. Thank you for joining us.